I am really pleased to present what I think is the perfect speaker for this morning's session, interpreting audit findings into what really does mean, this means for services and even more importantly, to patients. Professor Simon Noble is a medical lead for Thrombosis UK and a Marie Curie professor and supportive in palliative medicine in Cardiff University and an honorary consultant at the Royal Gwent Hospital in Newport. His main research interests are in the management of venous thromboembolism in advanced cancer, the anti-cancer effects of heparins, and the quality of life associated with VTE. His work in the benefits of a dedicated CAT service has led to the emergence of new CAT services being established in the UK, and also in his own South East Wales cancer-associated thrombosis service, seeing over 500 new cases per year. Simon is chief investigator on the international Palliative study, which explored the impact of cancer-associated thrombosis on patients in different countries and healthcare settings, and is sat on several clinical guideline groups, including NICE, ASH-CAT guidelines, and several ISTH guidance documents. He's published over 100 original papers, 25 chapters and 6 books, so I'm absolutely delighted to welcome Professor Simon Noble. Thank you.
Thanks very much, Jo, and thank you to all you sad individuals who had nothing better to do with your time than come and listen to me wibble for an hour. So I've got a fair bit to go through. And before we talk about the audit, I just wanted to give you some background. And first and foremost, whilst my name and I'm the schmuck giving the talk, I'm doing it very much on behalf of the United Kingdom Palliative Care Trainees Research Collaborative, and 2 of the palliative care specialist registrars trainees who've been helping me with this is Alice Crabtree and Emily Kavanagh. So I give them immense kudos and credit for their work, and also to Charlotte Chamberlain, who chairs the group and basically set up this collaborative of trainees in palliative medicine who just wanted to do some widespread data collections to improve the knowledge base of our specialty. So I'm very proud and humbled to actually have been involved in some of their work. So what I'm going to do is I'm going to just talk very quickly about thromboprophylaxis, not just in hospices and palliative care settings, but also in general. Why has it become such an important aspect of patient care? Well, the bottom line is that without thromboprophylaxis, about 60% of all VTEs in the population, and this is something which has a prevalence of 1 per 1,000 people, about 60% of all VTEs would be related to hospital admission, usually occurring either within hospital or within 90 days. And actually the definition of hospital-associated thrombosis would be a thrombosis that occurred during hospital admission or within 90 days of their hospital stay. So that's what we were looking at without thromboprophylaxis. We know from some of the primary thromboprophylaxis studies done 20 years ago now that giving a low molecular weight heparin would reduce the rate of VTE by approximately 50%. And I think the important thing is that we now have hard data that a thromboprophylaxis strategy that people adhere to, and so the mandating of risk assessment and thromboprophylaxis in English hospitals through the CQUIN system has led to a 15.4% reduction in deaths of patients within 90 days after discharge. So thromboprophylaxis, risk assessment and thromboprophylaxis does reduce mortality, and it also reduces morbidity, because we have to remember that the long-term consequences of venous thromboembolism can be considerable. About 40% of patients can develop post-thrombotic syndrome, and the costs to the NHS are ongoing and immense. Now, when I first had an interest in thrombosis, I remember at my academic interview that the external said, you know, thrombosis, oh, that's not really a palliative care subject, is it? And I think this was reflected at the time, whilst most hospitals had a thromboprophylaxis policy, only 2% of hospices did. That's when I did a survey. I rang around, over 100 hospices in the United Kingdom to ask them about their thromboprophylaxis policy. Only 2% had policies, and one of their policies was, our policy is we do not give thromboprophylaxis. Time changed and there was some interest in VTE coming through. So by 2006, about 19% of hospices were developing thromboprophylaxis policies. And this was at a time that there was greater interest. And so the work being done with the inquiry at Parliament on VTE. And in 2010, NHS England mandated reporting of the risk of VTE, initially with a target of 90%, and then that was increased to 95%. But of course, this was also financially linked, so that there would be additional monies to hospitals and trusts if they achieved this, and there would be money withheld if they didn't. And so, that really did focus the minds, and people were far more likely to adhere to this. But of course, the independent hospices weren't mandated to this, so they weren't expected, or if they were, they certainly weren't forced to go along with this. And there's always been some resistance to thromboprophylaxis in the hospice setting. And there's various barriers, and we did some interviews with hospice directors as to why they didn't have a thromboprophylaxis policy. One was that they felt it wasn't a big problem, they didn't see many. Now, whether that's true, that we don't, we've got a lower prevalence in hospices, or actually that we're just not choosing to see them because many of the symptoms that the patients are coming with VTE, they're attributing to other things. So breathlessness could be anemia, heart failure, lung metastases, infection, etc., before you consider PE. And swelling of the legs, once again, the number of causes of leg swelling in patients with advanced cancer are legion. There was also a consideration that a large PE was a nice way to go. And whilst I don't think people considered it was nice dying of a PE, they were arguing that perhaps a sudden symptom-free death of a large PE may be preferable to a drawn-out, highly symptomatic deterioration with cancer. The truth of it is there's very little data for symptoms of PEs at death, but the one PhD by a guy called Havig in the 70s suggested actually about 60% of patients would actually take more than 2 hours to die of a PE, and it would be quite a frightening, distressing death. Another question that people had raised was that patients wouldn't accept a daily injection of low molecular weight heparin. Well, when we did a qualitative interviews with specialist palliative care patients, they actually said that was cobblers. It was no problem at all. It was a piece of cake compared to everything else they'd been through in their cancer journey. And they didn't like the idea that doctors were going to play God with them and say that they didn't deserve thromboprophylaxis and being treated the same as any other patients. That paper was considered so, so significant. It was at a time when the BMJ actually published qualitative data, and they did publish this paper. And then one of the other things that people did raise, which I think, I'd go along with this, is that, the studies done 20 years ago looking at thromboprophylaxis used outcome measures that weren't relevant to our patients. Radiologically apparent VTE, we're thinking about symptoms, and there was a large focus on survival and the outcome measures they had. They weren't looking at symptoms. They were looking at just confirmation of VTE because untreated VTE had a mortality impact. So whatever the data existed, it may not be relevant to our patient population. So to address this, and some of you will be familiar with this study, Claire White, Miriam Johnson, Max Watson, myself, and others undertook the HIDDEN study, which was a hospice-based study where we wanted to do a gold standard prevalence study and try and equate it to patient symptomatology. And so what happened was every patient with cancer coming, or every patient coming into hospice who was able to consent, having excluded those being admitted for end-of-life care, would be consented to have a 3-point compression ultrasonography looking for large volume clots in the femoral artery, sorry, in the femoral vein. To do this in 5 hospices, I was pretty impressed that, you know, to screen 1,390 patients, and we recruited ahead of time. And what I would point out is that of those who were ineligible, the biggest proportion, it's about 29% of patients were being admitted and were thought to be likely to die within 5 days. So already tells us about a third of our patients in hospices thromboprophylaxis isn't appropriate for. Of those who went on to have a Doppler and had and the scans were available, all of these were also looked at by consultant radiologists. We're talking about a very poor patient group. So Konofsky's score of 49, you know, these people are very reliant on nursing assistance to do their activities of daily living and to get out of bed, etc. And the mean survival of this population in the hospice being studied was 44 days. So these are not patients who get into your usual clinical trials. And only by targeting palliative care patients and studying them will we get the answers. They're not getting into the big studies. They're not getting into the anticoagulation studies because of all of these. Anyone with a life expectancy of less than 3 months doesn't get into them. So it's a poorly group of patients. And of those who had evaluable scans, there was a 34% prevalence of DVT. Now, because these were being done by research nurses who'd been trained in Doppler ultrasonography or in compression ultrasonography, it was clear when reviewing these scans that early on they didn't have as much confidence and weren't compressing the vein enough. And this was very clear when they were being sort of double marked or reviewed by the radiologist. And because we had sufficient number of scans, we actually excluded, therefore, the first 3 months of scans and considered that a run-in of the nurses just getting their skills up. So by removing the first 3 months of scans, looking at the evaluable scans, we were still seeing a 28% prevalence of DVT. And this is just femoral DVT. We're not able to pick up any calf DVTs. This wasn't kind of accurate enough. The staff hadn't been trained to do that. And likewise, we weren't picking up any PEs. So I'd be suggesting that on admission, as a very minimum, we're looking at 28% prevalence of large volume DVT in our population. So these people have already got a clot before they come into the hospice. So primary thromboprophylaxis is not going to be of any help to them. The other thing that was interesting is that in those who had a DVT versus those who didn't, there was no survival difference. Furthermore, there weren't any attributable symptoms to these apart from some swelling patients reported. But actually, they didn't report it to be such a bother that the team who were blinded to these results went to investigate them. So you've got a 28% prevalence of large volume DVT, which is causing those symptoms and is having no impact on survival. So I think that it would be reasonable to say that in those particular patients, thromboprophylaxis would have no place. The horse has already bolted. Now, the other thing we need to be thinking about is that every time you give an anticoagulant or an antiplatelet, In the advanced cancer patient, that has its risks. We know that there is a risk of bleeding with anticoagulation. We know there is a risk of bleeding with thromboprophylaxis. And actually in the cancer patient, as they get more advanced in their cancer, this risk goes up. And this is data from a French study in hospice patients, just under 1,200 patients. And there was clinically relevant bleeding of 9.8%. So clinically relevant bleeding is major bleeding, and clinically relevant non-major bleeding, which is basically anything that requires a physician evaluation or change in the medicines. Now, if we have a look at this population, what you can see here is that the majority of these patients, the major risk factors, obviously if they've had a history of bleeding in the past, or if they were receiving anticoagulants, or even more so antiplatelets. So in fact, if you were on an antiplatelet or an anticoagulant, the risk of bleeding or the incidence of bleeding was 11.8%. So without anticoagulants or antiplatelets, these patients are at risk of bleeding, but it is even higher in those on antiplatelets and anticoagulants. Another bit of data just to kind of focus the minds when it comes to anticoagulants in cancer. We looked at the first 450 patients that were in our cancer-associated thrombosis service, and we just followed them through to the end of life to see what happened with regards to their anticoagulation. So those were the spread of different cancers. And what we found out of the 200 or so who died, the majority continued anticoagulation until death or within 7 days prior to death. So whilst other drugs were being rationalized and people were stopping the unnecessaries, they were still continuing with the anticoagulants. And it was observed that 7% of these patients had clinically relevant bleeding or major bleeding in the last week of life if they were on anticoagulants. So once again, we have a drug which in the last week of life isn't really going to offer any benefits here. So I would suggest that any symptoms they had attributable to VTE would be managed with end-of-life drugs. And yet you continue the anticoagulant, their last week of life is going to involve clinically relevant bleeding in at least 7% of these patients. This was also a retrospective note review, so it's only those who had written down there was a bleed of significance would record it. So once again, this is probably an underreporting. So the message we've got here really is that you don't want to be anticoagulating your advanced cancer patients without good reason. And we need to have a better idea as well of whether or not we should be giving thromboprophylaxis to our patients with advanced cancer. Now, the hidden study I think is very useful because what it's really suggested to us is that if you have a patient who's had a gradual decline in their disease trajectory and a Kanofsky of 50 or lower, they're likely to develop a clot which is not going to give them symptoms or shorten their life. And so I think within a hospice setting, one could argue against thromboprophylaxis if you've had gradual deterioration and of poor performance status. But can these data be extrapolated over to the hospital setting? Because let's not forget, we've got hundreds of thousands of palliative care patients being admitted to the hospitals rather than the hospices. And you have the hospital specialist palliative care teams there saying, well, should we be, treating them the same as a hospice patient? Are they the same beast? So through the UK Palliative Care Research Collaborative, we conducted what we called the Big Fat Audit. And it was a one-day snapshot audit, which occurred on the 25th of February, 2021. So for those of you who can bear to think back, that it was actually at a stage where COVID was not the dominant reason for admission, thank goodness, for a short period of time. And it was undertaken as an audit, with the primary question being patients that are under the care of the specialist palliative care team, and that was the best way we could define a palliative care patient. You know, how many patients were actually having thromboprophylaxis management as per NICE guidelines? So how many were being risk assessed and had a documented risk assessment, and how many, just whether or not they'd had the risk assessment, was their management appropriate for the evidence of whether to give thromboprophylaxis or not. And this was undertaken in 52 hospitals and 67 specialist palliative care units. And through that, that gave us 1,125 patient data sets. And all of that on a spreadsheet is a hell of a lot of data to clean up and start to analyze. And once again, Alice Crabtree in particular is to be applauded for the work she did here. So just going to give you a few bits of data and then we'll try and talk it through. So I do apologize, you're just going to get blinded with numbers and I'll try and interpret what I can. I'm still getting my head around this data. I tried to get some of this analysed in time for this meeting. So this is the first time it's been seen. So 514 patients in the hospital, 611 in the palliative care units. And I'm just trying to compare them to say, are we looking after the same sort of patients? So male and female, you know, kind of about the same proportions. You can see that the hospital patients, twice as many will have had systemic anti-cancer therapies in the previous 4 weeks. And I think the picture we're sort of getting here is that some of these patients receiving palliative treatments or palliative chemotherapy, or some of the kind of immunotherapies, etc., may have been being admitted with complications of those. So having been well enough to have them, which is normally performance status 2 or below, but are then deteriorated during those treatments. So far more people receiving systemic anti-cancer therapies than in the hospice. And you can see that almost 3 times as many having chemotherapy, probably about 4 times as many having targeted therapies, although hormone therapy, radiotherapy, not much difference. This is a complex slide and I probably wouldn't have presented it as I have, but it's basically just giving you an idea that we've got a breadth of cancers and the usual common ones: lung, colorectal, breast, prostate. You know, there's plenty of those, but there is a spread of lots of others. And I don't think there's much difference you can really see there. I suppose the only major difference I'd say is that you have more leukemia patients in the hospital setting, maybe a few more lymphoma patients in the hospital setting. And that's not a surprise because often these people are requiring more blood products near the end of life as supportive measures. And also our hematology friends will also often look after these patients until death because they've known them for so long. But otherwise, I don't see that much of a difference in these patient groups. So this is the kind of first thing that we would say is, you know, had a documented VTE score, risk assessment score, being completed, and in both hospitals and hospices. So hospitals 79%, specialist palliative care units 71.4%. So quite interesting from that perspective about actually a documented VTE score in the hospitals. They're quite below that sequin target. But the hospices who are not required to do it, still a large proportion. But when it looks to say, was the management compliant with NICE guidelines, just under 90% for both. So how many patients were receiving primary thromboprophylaxis? And I think one has to remember, we've taken out those who were fully anticoagulated for other reasons. We'll come on to that. But you can see in the hospital, it's about 2/3 of patients are receiving primary prophylaxis, whilst in the hospice, it is a small, small number. And when you look at the reasons given, and these were anything that was a contraindication to low molecular weight heparin or end-of-life care, of course, because the NICE guidelines would say not to give it to people receiving end-of-life care. 30% of hospital patients, 30% of those who were not receiving thromboprophylaxis, it was due to end-of-life care, compared to 44% in the hospice. Quite a few patients, quite a large proportion, had a history of recent bleeding of the hospital patients. And then thrombocytopenia was another issue for some of them. And I think once again, we're kind of getting that picture, maybe those coming in with the complications of their systemic anti-cancer therapies. But quite a few proportion, they didn't have a reason recorded why they didn't get it. But you can see here that in the hospital setting, more patients are receiving thromboprophylaxis. Any other differences? Well, the hospices their populations do tend to be older. So it is a slightly older proportion of patients. And the other thing you can see here is those in the hospice as well tend to overall have a poorer performance status. That doesn't mean there's still a large proportion of patients in the hospital with a Karnofsky of less than 50. But, the majority of the hospice patients have a Karnofsky of very poor performance status. And we can see here that patients are admitted, the proportion of patients with different reasons for admission varies. So I think the first thing I would say is that in the specialist palliative care unit, you can see there is just under a quarter of the patients are being admitted for end-of-life care, whilst there's none to be seen on that pie chart in the hospital setting. The other thing is, if you look at the turquoise section, these are the patients who've had a gradual deterioration compared to those going into the hospital. The majority of hospital patients are those who become unwell acutely, whilst the majority going into the hospice are those who are either dying or are gradually deteriorating. And I personally think that this reflects a self-selection by patients and community palliative care teams. If you have someone who's been deteriorating over time and you've been trying to get everything arranged for them to manage at home, or it's not working, or they don't want to be looked after at home, or there's some breakdown in care or communication, and a decision is made that they need to be admitted, they'll often say, I don't want to go back into the acute sector, but they'd be willing to go to the hospice, and they'd be willing to wait for a bed. We often have a waiting list for beds. And so I think these are the people who have been deteriorating over time and would be prepared to wait. Whilst if you have a sudden complication, something goes wrong, that was unforeseen, you're more likely to admit them acutely and give them the benefit of the doubt for treatment to see what will be reversible. So these turquoise patients, the gradual deterioration ones, their performance status will not only be low, but it will have been getting low as part of a trajectory of deterioration. Whilst those that we're seeing in the hospital who have a poor performance status, it is often an acute deterioration which has led to that. And these people, therefore, their trajectory getting to a Karnofsky of less than 50 has been sudden, having previously been a good performance status. So there would be a case there that those people may improve again, and therefore may be those who would benefit from thromboprophylaxis. So my mind's kind of erring towards the side that I'm not sure that the hidden data can be extrapolated over to the acute setting here. If you look at what proportion of patients are coming in on anticoagulants or antiplatelets, which as per the data I've shown you are a significant risk factor for bleeding, it's pretty similar. So anyone who says that VTE, anticoagulants are not a palliative care issue, I'm afraid they are. You know, in your hospice or your hospital, a third of your patients are on these medicines. And so you will be having to consider them. What are the indications? Well, in the specialist palliative care unit, and there's all sorts of different concoctions as to what someone is on and for why. And I won't go into too much detail about that. But what you can see is that 41% have got a history of VTE, so they're anticoagulated either on, usually on low molecular weight heparin or a DOAC. Atrial fibrillation, 17%. So the people who've got them on low molecular weight heparin for AF really need to go to a couple more of my lectures. We don't use low molecular weight heparin for AF. So the majority on DOACs and some on warfarin. And then ischemic heart disease, over a third of the patients have ischemic heart disease and are on antiplatelets or dual therapy. You compare that with the hospital, 35% VTE, larger number ischemic heart disease, and then 23% AF. So a lot more patients with cardiac histories rather than venous thromboembolism histories. So that's the data we've got at the moment. I do also have some charts which I'm working through at the moment saying what proportion have Kanofsky and a gradual deterioration. Sorry, Kanofsky of 50 and a gradual deterioration. What proportion have Kanofsky of 50 and an acute deterioration? Can we work out who would be at greater risk of clots or who would already have thromboses? And that's going to take a little bit more work. But clearly what we really need to be doing is repeating hidden study in an acute hospital setting. And actually today, the Welsh Health Research Wales has announced the successful grants for research for patient benefit. And we've been awarded money to conduct hidden 2 in an acute hospital settings. So we're hoping in 2 years' time to have data from that, and that'll tell us, you know, how big the problem is in the hospital, whether it's similar patients or not. But what does this data tell us? Well, number one, well, the data analysis is ongoing, and we need our statisticians to come in and help us and have a look and try and tease some things out. But I think we can safely say that the hospital and the hospice patients as a whole do differ. The reasons for admission tend to differ overall. Their disease trajectory prior to coming into hospital will be different. Their performance status, I think, overall is different. And also the proportion that have had anti-cancer therapies differs between the two groups. But I think there's similar indications for anticoagulants and antiplatelets, and the proportion of people taking those is similar as well. And so our kind of skill set as palliative care teams needs to be as good in both environments. Do these data so far have any implications for us? Well, I would say, of course I would, because my whole research career has been based around it. So therefore, I don't want to say everything I've done has been completely irrelevant all my life. But I do think that the management of anticoagulants is of considerable relevance to us as palliative care teams. But I think we may face different challenges in the hospice, the specialist palliative care unit, and the hospital. I think in particular, there is a relevance to advanced care planning, that we know that as death approaches, these patients' risk of bleeding goes up. And I think we need to be considering antiplatelets and anticoagulants in a certain patient groups as drugs that we should be rationalizing as death approaches. Identifying the timing for that at the moment, I'm not sure. But if I've got a patient who I think is, nearing the last few weeks of life, I will be stopping the drugs that could make them more likely to bleed. And at the moment, I don't think the data that we have from the hidden study is going to help us too much in the acute setting. I think the populations are different, and I think it'd be dangerous, probably nihilistic, to apply it to the hospital population. So I'm hoping I've kind of left you with time for questions. I think these data at the moment does kind of create more questions than it does answers. But what I also want to do is just show you that it is possible in palliative care to generate large amount of data, but it really requires collaboration. And I'm just going to put out the names here of all the people, all the teams who have contributed to this, and actually registrars, consultants, senior nurses, pharmacists who actually took up their time to actually, or not only to conduct the audit, but to get it through their local approvals. All of these people who have taken up their time, and I am incredibly grateful for that. So I'm very happy to take any questions. And thank you very much for your time and for listening.
Thank you, Simon. That was really interesting and extremely thought-provoking as well. We have a question coming from Helen Philippou, whose praises were great talk. If bleeding side effects could be addressed by targeting the contact pathway, which cancers do you think would be best to treat with the contact pathway inhibitors? What a question.
So Helen, I need you to give me a bit more explanation. Are you talking about which cancers would be best to anticoagulate, or are we talking about which ones should we? I think I'm needing a bit more data. I'm not quite sure what the question is. I'm sorry for being stupid. If someone else wants to help me out, I'll be very happy to.
Find Helen, and if possible, Helen, I think you might be able to unmute yourself now and be able to talk.
Hi, yes. Can you hear me?
Yeah.
Yes, so I was just more interested in which cancers involve more of the contact pathway, so which would benefit more in that regard. Does that make sense?
When you mean contact pathway, what are you talking about?
Well, I guess more some cancers might trigger the extrinsic pathway over the contact pathway.
Yeah. Okay.
So, yeah.
I mean, basically, most cancers, the thrombotic risk is generated by tissue factor.
Mm-hmm.
And so, you're even having your bleeding, anything that kind of comes before your common final pathway, which where a lot of the bleeding kind of is at risk, and you will see that with your warfarin. But it's not just a matter of the kind of coagulation pathway, of course. We're talking about the other issues are going to be platelet activity,
Mm-hmm.
not just thrombocytopenia, but platelet inhibition. It's also to do with actually clot structure and behavior. So, some clots that form will kind of contract quite quickly and form a very solid mesh and won't be at risk, and other ones will be very loose. And let's not forget as well that our patients can often be in a degree of disseminated intravascular coagulation. So I think it's a bit too complex to be able to identify one particular area. And I think wherever you anticoagulate, it's not that we make people bleed, it's that when they bleed, we slow down the clotting process. If we were to put a microscope into my brain, we would see that I am constantly having spontaneous micro hemorrhages. And the reason that I'm not having an evolving stroke in front of you is because my coagulation system is clotting, is, forming clots, which then thrombolysis will reabsorb over time very quickly. So it's more it's not so much that we're kind of targeting the wrong pathways. It's just the fact that by anticoagulating, we have got the risk of bleed will be greater. Also, it's because of the DIC, as I said, and also we have these highly vascular tumors. So that's why we're seeing greater bleeding in those.
Okay. Thank you.
Don't know if that's been any help. But
yeah. No, thank you. That's good. Thanks.
Thank you, Simon. We also have a comment from a lady called Paula, who says, are you confident that the patients admitted to hospital were true acute admissions? It is not uncommon for general deterioration to be unrecognised. So that's obviously a challenge in doing this.
Yeah, I'm as confident of the accuracy of that data as I am of any of the other data entered. So there will be, when people did this, there will have been a reason for admission. And what they will also have attempted to do is get an idea for what the trajectory was. So, it's as confident as one can be. Nothing is nothing can be certain. If I were to take that another step, all of the data that we base our healthcare policy on will be coded data from the wards that the ward clerk, if you ever wonder what they do, apart from show you where the blood forms are, they are entering data on the conditions that each patient has had. And so those data are only as accurate as the person entering it. So I think this argument or this concern goes far more widely than just this audit. But we're as confident as we can be.
Okay, thank you. And an interesting point from Marianne, who says she found your talk very interesting, very helpful, but it's something she always finds difficult, particularly when patients are on them for symptomatic or recent DVTs, PEs.
Yeah. So I think that's an excellent point. The way, whenever I make a decision regarding continuing or stopping anticoagulation, I consider certain things. One, I will consider how big was the clot, because that may tell us if this person has a greater risk of recurrent clot. I want to know how old the clot was, because for you to be able for that clot to stabilize and be at lower risk of recurrence or of embolizing anywhere, you need to be anticoagulated for 6 weeks. So a patient who has a fresh clot, I would be more hesitant to stop anticoagulation if they were having symptoms from it. I think near the end of life, our goal here is symptom control. And so if that DVT is painful, yes, I would anticoagulate it. I would hope that the main acute symptoms they're going to get will go down after a few days, because actually lysis and clot resorption and contraction will occur very early on. And that's why you see people actually get some symptomatic relief from their DVT right from the start of anticoagulation. Also because the heparins have a slight vasodilatory effect. So fresh clot, I may be slower to stop anticoagulation. Old clot that's been treated for some time, I would be more comfortable in stopping. If you think about how long it takes from someone who has the kind of incident insult that leads to their increased risk to develop a symptomatic clot, it's about 14 days for someone to have a symptomatic DVT and 21 days for a PE. So if I've got someone who I think's got a couple of weeks to live, I think the likelihood, having stopped the anticoagulation, that they're going to get a significant symptoms from this, I think they may not even live long enough to get them. But I would also be thinking about, well, can I manage this with end-of-life drugs? So I think it's how old is the clot? If it's fresh clot and they're highly symptomatic, yeah, by all means. But what I'm trying to say is if you've had some guy who's been what I'm seeing is people who've been anticoagulated for 12 months for an incidental pulmonary embolus, and they're having a major bleed at the end of life because we could have stopped that anticoagulation a long, long time ago. So was it an incidental PE? Was it symptomatic? How old was it? And as a rule of thumb, older clot that's been anticoagulated, I'm going to have a lower threshold for stopping.
And there are a few questions, but just to go back to that same question, somebody said, can you just clarify that last point again? After stopping anticoagulation, it would take 14 to 21 days for symptoms to reoccur. Is there a question?
Okay, so I think there's an extrapolation of data here. We know from orthopedic studies that people who, if you have an operation without thromboprophylaxis, and these people then go on to develop clots, it's usually about 14 days from developing a DVT from that index point before they become symptomatic. You very rarely on day one with no clot in the leg go to day two, big fat swollen leg, because that clot has to build, and it builds in sort of sheets over time, and it becomes symptomatic once it has occluded the vessel, and then there's a build-up. So that takes time. Likewise, people getting symptomatic PE, on average, not every person, but on average, it's about 21 days. So the point I'm making is that if you've had someone who's been anticoagulated for a long time, so we're not expecting them to have any clot remaining, or if they do have residual vein thrombosis, we're talking about a slither of scar tissue on the side of the vessel. It's going to take time before they develop more clot.
Thank you. Yeah, that's really helpful. Thank you.
You're welcome.
One of the hospices has said they think that they had to submit latest blood tests in the audit. Yep. Was there any learning from the LFTs?
At the moment, no, because we've not got through that data yet. We've still got all of that to look at. We worked very hard when we were looking at all the data to try and make sure it was of relevance, so that we didn't have people wasting their time. So we're still looking at that, because what we're trying to also get a picture for is how many patients were we looking at, had liver disease, how many patients had thrombocytopenia, were anemic, etc., and trying to tease that out. So we don't have those answers yet, but it is on our to-do list.
Thank you. I'm sure this is also on a to-do list, but from this learning as well, what do you think this will bring into the education side? Because obviously there's education for hospitals, but also for hospices and maybe for community care as well, where patients within this cohort, but may well be staying at home and managed there, so, which is really complex and challenging. What do you?
Yeah, I mean, I think one of the kind of holy grail of sort of advanced disease and thrombosis is kind of what should we be doing in the community. Arguably, a lot of the patients who were in the original studies 20 years ago would be managed in the community these days. Your patients in those hospitals, they were having Dopplers done, and they were in hospital for 14 days. You had a lap chole done, then you would be, bed rest for 5 days or something. And now these are day cases. So actually, I think there's a lot of stuff going on in the community that we really don't know. And the NICE guidelines are very careful to say this is for hospitalized patients. I think the most important message from this is that the days of one size fits all with regards to thromboprophylaxis, I think are changing. I think they're coming to an end in certain ways. I think the strategy of the thromboprophylaxis policy You know, we can see that it has improved care, it has saved lives. But I also think that the populations of patients are becoming so more diverse. Those studies only had 15% of patients had cancer. And actually the cancer patients are different now to what they were like 20 years ago. So I think we have to look at cancer separately. I think we also, as palliative care physicians, need to be confident about individualizing care. Oncologists need to be confident about individualizing care. You know, I often say that I find, you know, beggars belief to me that we will make a decision on immunotherapy or chemotherapy based on the genetic analysis or molecular marker. And that tiny thing will tell us whether or not this patient's cancer will respond or not to that treatment. So we're having such precision, individualized anti-cancer treatments, and yet our management of one of the commonest complications of those treatments is similar for every single cancer and every single patient we have. And that just seems very strange. So I think we should be looking to individualize our care a lot more. I think the other thing that people lose sight of, and I'm not, you know, I've sat on many clinical guideline groups, and I'm still in therapy, because often these groups are very happy to go, we can do this. The data says you do this. The data says you do this because we've got this meta-analysis and the diamond on the forest plot says X, Y, and Z. But they're absolute bugger all help in what we do with the patients who never got into those studies. And you look at these studies, and so, for example, for me, looking at DOACs in cancer patients, only one of those papers of all these studies showed how many patients were screened that were ineligible, but it was 50%. So we don't know, you know, 50% of our patients were excluded from these studies. So, you know, the data may not be appropriate for them. And the guidelines all say, well, we don't know what to do there. All we can say is you can't do this, or we don't have data to support it. And yet people have become so obsessed about evidence-based medicine, but they've forgotten that evidence-based medicine is composed of 3 elements. One is the data. So that are your RCTs, your systematic reviews, your meta-analyses, and that is one circle of the Venn diagram. The other circle of the Venn diagram is clinical experience. And the third circle of the Venn diagram, I only have 2 hands, so this picture ain't going to work, is patient preference and values. And at the moment, if I look at those 3 circles, it feels to me like we've got this humongous beach ball representing the data, and clinicians feel that they've been relegated to a little tennis ball of relevance where it comes to their experience, and patient preference is a little ping pong ball. So these are not considered with equal weight and importance. And in palliative care, where we have zones of indeterminate practice on the evidence front for just about everything we do, we need to use the data we have, but be confident in just trying to apply it with common sense. So I don't think we should be afraid to do what intuitively feels right. And I think the bottom line is we are looking with our patients as to what is the symptom burden, what is the likely symptom outcome if I stop this medicine, what is the potential hazard of continuing it or stopping it. But we've got to kind of, I don't know if reclaim is the right word, but we've got to remember that we are clinicians, you know, and medicine is an art, and the data and the evidence is really, really helpful, but it is one component of evidence-based medicine. And I think we've lost sight of that.
Thank you, Simon. That's very intuitive and a really important lesson to remember. because of the complexities and so much of the work you've done has shown the benefits of a dedicated cancer-associated thrombosis clinic, are there opportunities in Wales and England or the UK as a whole, where when there are these complex cases where everybody is an individual, there's opportunity to talk and discuss with other team members? And is that evolving as this gets better recognition?
Yeah, I mean, I'm very fortunate that myself, Nikki Pease, who's a palliative care consultant, and Raza Alican, who's a consultant hematologist, we have a cancer-associated thrombosis MDT. Well, we call it an MDT. I mean, we're the only discipline there, really, but all other specialties are welcome. But we have a meeting every Tuesday and discuss all the new cases, and in particular, the difficult ones. Now, what is fascinating is that Raz, who is a hematologist with immense research experience in thrombosis, in fact, the Medinox study, which is the one that's basically directs thromboprophylaxis policy, that was his study. So he knows his stuff. And yet whenever we talk about managing clots, when he first came along to the meetings, it really was that classic thing of, to a hammer, every problem is a nail. And so all he would do would be, how do I anticoagulate this? How do I anticoagulate this? And once in a while, Nikki and I would say, well, the patient's 90, it's a tiny clot and she's asymptomatic, and she's had a bleed. Maybe we don't anticoagulate it. Or maybe now is time to stop this. And he's kind of become more used to actually putting the patient first and seeing what the patient's agenda is, and what means more. So we're very fortunate that we do bash around some of the more complex patients. I do get emails. I probably get an email every week from a palliative care colleague going, I've got this challenge, I've got this problem, what do you think I should do? But I think what you're really saying, Joe, is that I do believe that CAT is becoming a subspecialty of its own. I'm trying to encourage the registrars in haematology to attend the CAT meetings, because the advice that they give at the moment when asked on call is very much what the guidelines will say. But half the time people are ringing for advice, it's because actually the patient they're looking after falls outside the guidelines. And we therefore need to actually sometimes bash around the best way to manage.
Okay, thank you very much, Simon. There is one last question. So what is your least favorite tumor when it comes to anticoagulation? So quite a different discussion.
These days, I would say esophageal. And my reason being, number one, you can't use a DOAC on them. Number two, they are clotty as hell. And we also give them chemotherapies which make them even clottier. So they often get quite resistant clots. These people tend to lose a lot of weight, so we're keeping them on low molecular weight heparin, and they're losing body mass, and so it's harder. They are one of them. The other one, which always gives me sleepless nights, will be glioblastomas, because brain tumors are highly thrombotic, but of all the tumors, anticoagulation does carry with it a much higher risk of intracerebral bleeding. Some cases would have reported up to 25% of patients have intracerebral bleeds on anticoagulants. The other thing is, though, although the data suggests DOACs may be okay for them, glios weren't involved in those studies, so it's just case series. And also, dexamethasone is a strong inducer of CYP3A4 and P-glycoprotein, which means that dexamethasone will reduce the anticoagulant effects of DOACs. So DOACs are a challenge to give to these patients. You want to anticoagulate these guys, but you're running a big risk of them bleeding. So those are my two, glioblastomas and esophageal. Pancreas I hate for every other reason as well. They're buggers to treat. They're all buggers, really.
I guess what it comes back to is what you explained just now, those three things of data, clinical experience, and patient benefit and values, preference, ultimately. Simon, thank you so much for your time this morning. Really interesting. But for now, thank you so much.